Hi there, this is Shem, known as Shem, doing a podcast. And the guest today is this wonderful man who is a colleague of mine at NYU Medical School named Fritz Francois. And he's going to talk with me about what's not humane in medicine right now, which is, in his view, inequity and what to do about it. So these are the same things that I've tried to write about in the new novel, Man's Fourth Best Hospital, and it's about putting the human back into healthcare. So buckle up and listen. Welcome to Conversations with Shem. Focus is to show how to put the human back into healthcare.
We are excited to welcome Dr. Samuel Shem, author of The House of God and Man's Fourth Best Hospital, and professor of medicine and medical humanities at NYU Grossman Medical School. And sitting across from him is going to be Dr. Fritz Francois, the chief medical officer at NYU Langone Health.
Hello, Fritz.
Good morning, Shem. How are you?
Yeah. Good. Thanks for coming on this show. It's a real pleasure. The only way I get to see you.
Well, thank you for the invitation.
I think this is very just let's talk. And the two things I would suggest, and it comes out of some of the work we've tried to do together, op-ed, et cetera, is what's not so good with medicine right now, and what do we do to make it better? That's all.
It's a heavy topic. It's a very heavy topic.
Yeah.
So before we begin, let me ask you, when you pose the question in terms of what's not so good about medicine, like, what comes to your mind in terms of why that question actually just came up for you?
Well, yeah, as you know, what is it, 7 years ago, I got this invitation to join NYU Medical School as a professor of medical humanities. And for the first time, I was in it again. I was in medicine again with fresh eyes, because I'd been out of it, just a writer. And I saw right at the beginning two things that really, when I went on rounds, I saw the miracles we do, but I also saw what I call money and screens. And I thought, gee, this is a time when medicine could either go toward more humane care or toward money and screens, meaning the screens being partially billing the screens that doctors are enslaved with. And so that led me to write Man's Fourth Best Hospital. And so those were, and I took it as my job as a writer to describe this, and then maybe at the end try to figure out what to do about it. And it was a sequel to The House of God. So I have the fat man there helping me. So that's what's gotten me back into medicine. I've been there for 7 years and met people like you. And frankly, I would say of all the places I've been, and they're almost all of them all over the world, country, with doctors and hospitals, NYU is really the most compassionate and intelligent, and with the right values of connection, of good connections all the way through, of any I've ever seen. So I'm happy as a clam. So that's sort of where I'm coming from.
Well, it's great to hear that, Shem, because and it's interesting that you actually mentioned this aspect of the screens, and I think you're referring to technology that exists and the importance of seeing people. And if we could leave that aside, how are we seeing people? And I'm not just talking about patients, but I'm also talking about the members of the healthcare team.
Yeah.
And that resonates with me on many levels. And if it's okay, I'll share with you actually why. And it actually will shed light on even how I began my journey
Yeah.
in medicine, and why this is so important to me in terms of putting the human back into it. And so, I've often asked, and I just perhaps you've been asked, like, why did you get into medicine, or what does that look like? And I one of the key moments for me goes back to high school, writing a report where I chose as the topic HIV and AIDS, and decided actually at the time, because we didn't have screens, we had books, and my parents actually had purchased, worked hard and purchased actually for us, for the children, actually a series of encyclopedia, and I picked one of them to do some background research on HIV and AIDS. And you go into it, and then you have a paragraph, and as I'm reading it, came across what is now known as, and what I learned is, the 4 H's of HIV and AIDS, which were heroin users, homosexuals, hemophiliacs, and this is exactly verbatim what it was in there. And the 4th H, Haitians. That's my background.
Yeah.
I'm Haitian. And so immediately I'm reading this and recognize that something is really terribly wrong here. That by virtue of the fact that I'm Haitian, that somehow I have HIV and AIDS. And I read it and just, immediately again, I felt like I need to be one of the individuals who's doing research and who's helping to put the right information in these types of books. And lo and behold, the consequence of that information was deeper than I would ever imagine. And in fact, what happened is that the misunderstanding of how that came about, by the way, led to Haitians being forbidden to donate blood in New York. And as a consequence, they also suffered terribly in terms of, now you have an entire group being ostracized, and there are individuals who couldn't get jobs. They could not get care because, hey, if you're Haitian, it must mean that you already have HIV and AIDS. And it led to...
When did you come to New York?
I came to New York in 1981.
When
This was in the mid 80s, just as obviously the AIDS epidemic actually was just starting. People were struggling to understand what was going on. And of course, if you go through it, 3 of the 4 H's one could understand in terms of, like what might have happened here. The 4th wasn't understood very well. So how in the world do we connect the dots in Haitian? So here's what happened. So it turns out that some of the early patients who presented actually with HIV and AIDS were young Black males who happened to be Haitian when they were taking a history and they were trying to connect the dots in terms of what FDA said, in terms of including whether they had sex with men, etc. The answer was no. And so they couldn't figure out anything to use any IV drugs, no, etc. Well, there was an important element here that was not understood by the epidemiologists doing the work, which is that in the Haitian culture, especially in that time, to say that you are gay would be almost like a death sentence. You would be ostracized, and it wasn't accepted. You cannot be Haitian and gay. How in the world did that happen? And these individuals, these patients, knew that. And so they did not put that information out. And so the only thing that then they could figure out as far as the pattern is that you had these Haitian patients presenting with HIV and AIDS, unexplained. And therefore, there it is. It must be a Haitian thing. So no, that was a terrible error, misunderstanding. And of course, that entire group paid for that. And so the consequence of, in terms of putting, when you say putting the human back into medicine, to me, it's also about that kind of understanding people, understanding cultures, understanding why was it that these patients did not feel comfortable talking to the doctor about their fear, about what was really going on. Were they really seen? Why does that matter for me? Well, it's interesting, as I said to you, that this prompted me to begin my journey in medicine. But there's also the reality of who I am. Yes, I'm a Black male. Yes, I am Haitian. And it meant that I also was just one of the few. And throughout my journey, actually, was, again, being one of the few. And how am I seen, or more importantly, not seen? And so today, when you talk about putting away the screens, one of the most interesting things that I'm dealing with, and that I continue to deal with, is how we see one another
Yeah.
as physicians, or how we do not see each other as, and how patients, again, like, don't see each other. So I will tell you that when I was training, it was not uncommon, if I wasn't wearing a white coat, to walk into a room and for patient to mistake me for the person who's there to turn on the television. And so and unfortunately, I wish I could tell you that, that these aspects of how patients might engage with physicians or with others in the healthcare field who do not look like them has changed drastically. It has not. Or even the way in which we as a healthcare community are really dealing with these issues with one another. No, and the evidence of such obviously has recently exploded with the podcast that you're well aware of, actually, in terms of talking about structural racism and thinking that this doesn't exist anymore. And so to me, this is a really important issue in medicine that we need to address if we're really going to put, again, the human aspect back into medicine. Because there are whole groups of individuals who feel not only not seen, but have not been heard. And therein lies the problem that we absolutely need to tackle.
Yeah, that is, well, you've taught me a lot about that, because we have worked on this issue in terms of the Hippocratic Oath, that we wrote that piece, that op-ed piece. But how can Black Lives Matter change the Hippocratic Oath? Because there's nothing about equity or something being equitable in the oath that everybody takes. And that's just a little example about how you and I with you have tried this. I mean, this is such a lasting, difficult, stupid time in not having that for doctors. It's really something, and you've dedicated much of your life to that. And I was glad to join you in that little piece. But that certainly is something that's not very human in medicine, because you're leaving out lots and lots and lots of people.
Yeah, absolutely. And we've learned a lot during this past year
Right.
of the pandemic. And perhaps one of the most interesting things that it exposed is exactly what you just mentioned, which is that, yes, the disparities still exist, but we are far away actually from achieving true equity. And I say that because there's an interesting experiment, and I pardon me for using the term experiment, but one could think about it in those terms that happen, where we know that there were patients who were coming in and who were infected actually with the COVID-19 virus, Some of them were needed to be admitted. Some of them actually were not. And what we saw was that individuals who were, once they were admitted, and by the way, before they were admitted, you could look and see that we know that the infection rate, those who are getting COVID-19, it was higher in the minority communities and the Black and brown communities. You could even look by zip codes in New York City, and you can map it, and you could say, yes, the infection rate is highest in there, et cetera. So we knew this. So some of these individuals needed to be hospitalized. And lo and behold, if you structure things in such a way where you have a single playbook, doesn't matter whether you're Shem or you're Fritz, etc., we're gonna get the same type of, here's a single playbook, this is what we do, etc. And you ask the question, are the outcomes the same? The answer is yes. In other words, within the walls of a hospital where care is provided in an equitable fashion, you can expect that outcomes will be the same. So the issue really isn't there. The issue is really what happens outside the walls. What are the factors that were existing that led to the risk for that particular individual or that particular community? And then you look at the living situations and all the social determinants of health that one can talk about that then provides that risk. And so we haven't really dealt with that. We haven't been dealing with it. And this is what the pandemic actually exposed. Not that we did not know it, but it's, I was having a conversation with someone and said, in a way, we've made the mistake at times of thinking about equity as a zero-sum game. It's not. And what happens now, and what perhaps has changed actually with the pandemic, is that we recognize that we cannot afford not to deal with these issues because there is a risk to all of us. Because obviously, like in certain communities, not as if you were going to really try to, say, as an example, take Queens, an area in Queens, and say, we're going to wall it off. You don't have that luxury. So we're all in this, so that we know that the transmissibility of the virus, and the longer it takes for us to deal with the virus in a variety of ways, even now with the vaccine, that the variants can take roots. Not only are you spreading it, but then variants are taking roots. So you're in this interesting race, so that you have to deal with these things holistically.
What can you say you would like to do? What are the things that you would try to get the humanity in terms of equity into medicine? That's an easy one.
Of course. Well, you know what? It begins actually with listening. And it sounds simple, but I say to you that it begins with listening, because I believe very strongly that if we take as an example a vaccine hesitancy, and you say, well, how do we solve for that? How do we deal with that? And you say, well, we're going to go in and we're going to tell people vaccines are safe and they're effective, which is true. But what if we actually began by listening to the concerns and why? And you listen to the history from that specific community. Now, I just shared with you how I got into medicine. So that if I go to Flatbush, Brooklyn, and you're listening to a community that says, back in the 80s, this is what happened to us. We had to march across the bridge, one of the biggest marches ever, across the Brooklyn Bridge to City Hall, to ask them to stop doing this to an entire group of individuals, that it was wrong, that what was going on, that people were suffering, people were ostracized. I mean, kids actually were getting beat up at school, people were losing their jobs, people couldn't, were being refused care, all because something was misunderstood. Didn't listen. So fast forward, and we're in a situation where there's a pandemic, and we want to say, well, we want to give you this vaccine, but we are not listening to the why. Why are people hesitant? Why are they afraid? Well, here it is. It's not just about the vaccine. So the solution, Sam, is this. We have to listen. We have to engage in a dialogue about the vaccine, But once I give you that shot in the arm, I need to promise you that it's not over. My
Mhm. Yeah,
commitment is to
yeah,
you and to the community.
right.
We have more work to do. If I believe that I'm going to parachute and just give you a shot in the arm and that's it, I'm not listening, because that's not what that the community needs alone. There's more, because the situation that's happening, and whether it's a Flatbush, Brooklyn, or Queens, or certain areas, etc., there's more. How are we investing in those communities?
Uh-huh.
How are we addressing the food deserts, etc.? So that's what I mean. This is really the way in which we have to put human back into medicine, because to me, that is medicine. It's a different way of thinking about it, in terms of, not just saying I have a drug and I have this and I have this diagnostic test, etc., but really thinking about your population health in that
Yeah.
way.
Yeah. And of course, lots and lots and lots of people in public health are trying to do that. And what do you think about what's going on, and is it working? And are there other ideas that you would have? Certainly listening is number one.
Yeah, I think that we recognize that there's a problem. To say that actually, we know that there's a problem. It's there. Are we where we need to be? No. And the reason I say that is because it does require investment, and not only like from literal investment in terms of money, but time and people, and think about how we are doing how we're investing actually back in those communities and engaging the communities themselves in order for us to improve health. We are not where we need to be. And if you can challenge me and you say to me, well, how do you know that? And I would say to you, look at the past 18 months. There's, I think that provided us with so much evidence and so much data in
Yeah.
terms of what I'm saying to you. And that's the lesson. Question is, have we really learned from it? And are we ready to do this? And I think time, the next 6 months and year, will tell in terms of our ability to take a different approach. And we cannot take the exact same playbook from many years ago and pretend that this is going to work. This is why we are still facing issues regarding vaccine hesitancy in certain communities. That's the reality. So we have a lot more work to do.
Yeah. Yeah. Anything else specifically that's, that if you could write out, what specifically should we be asking about, or who should be at the table and how, that kind of thing.
Sure. I think that, one of the interesting things that I continue to do is to make sure that we open the door for individuals who should be at that table and should
Uh-huh.
be and have ideas, etc., and give them opportunities. And often we don't do that. We don't think about that in those terms. And part of the reason is because they might not have the opportunity to be at the table. So here's what I'm talking about specifically. So of course, I could spend a lot of times, and I know a little bit of it about my own journey, and I made reference to the fact that, that there was a time in my career, or, when I started medical school, I was the only person who looked like me in my medical school class. That's just the reality. So part of my goal was that to make sure that I'm mentoring individuals and that I'm changing that, so that I am not the only one who's actually at the table. Well, why does that matter? Because I just spent a few minutes now talking to you about my perspective, my way of looking at and thinking about medicine. But I do so because of the perspective of who I am. I can't separate that. That's who I am. I do so knowing full well that there's certain luxuries that I will never have, which means that, yes, I am a physician, but I am also a Black man. And I know that that the way in which I experience the world is as such. In fact, when I walk down the street, people might not know that I'm a physician, but they certainly will recognize me as a Black man, meaning that way in which I experience that actually is different. We need to understand that, and we need to make sure that as we think about medicine and shaping medicine, that there are more individuals who have such diversity, that we continue to work on diversity and inclusion, because that makes us better as, in terms as a field, because otherwise without such perspectives, we miss it. We miss the things that we should be considering as we consider issues related to women's health or LGBTQ health, et cetera. We miss that. And I think, to me, that really is perhaps one of the most important things that we can do right now at this moment. Like, that when I say do it right now, it should have been started years ago. But that's the work that I'm so committed to, because that is our future, quite frankly, as I see it. I want to thank you again, actually, for just inviting me just for a few minutes, actually, to share this with you.
Thank you. And
so
I
much.
would say just one other thing, that the NYU group, the whole 47,000 employees, et cetera, I think is really trying hard to do some of the things that you're talking about.
Absolutely.
I think that's why I like it so much. It is that kind of thing. It's right at the forefront of their mission.
And I will tell you, Shem, to your point, this actually speaks to our commitment, because we have, as you know, recently launched the Institute of Excellence in Health Equity.
Yes, I know.
Underscores NYU Lincoln's health, not only understanding of why this is important, but commitment to do exactly the things that I was just making reference to along the 3 mission areas of clinical care, education, as well as research. So it is exciting time for us, but this is what we're going to do.
And I'm joining that.
So absolutely.
Thank you so much. Well, what a guy, what a fresh air is blowing through the screen here. He is absolutely using the way he grew up into being a doctor to try to help with a major inhumanity in medical care in the United States, a terrible inhumanity of people of color not getting the same care. And that certainly is something that we're hoping to move forward so that it's no longer true. And I think the COVID is a great teacher in how to make this better. Thanks for listening.